exhaustive list of causes. Okay, so the abnormality where gone wrong could be neurogenic, high up, neurogenic in the brain. Either patient ada Horner syndrome, cranial nerve itself yang defects, cranial nerve palsy, or myogenic muscle problems. Okay, like patient with muscular dystrophy, ataupun chronic progressive external ophthalmoplegia. Okay, and then if it's not the muscle, is it at the junction? Macam I mentioned earlier. This is how you go about to determine the level of abnormality once you detect the abnormality. So NMJ like myasthenia gravis, they can have ptosis. Alright? Or is it mechanical? Okay? Because of direct eyelid tumor. That's why they cannot open the eyelid properly. Okay? Or degenerative. For example, levator aponeurosis degeneration. That's degenerative condition. Okay? Okay, so nerve supply of your extraocular muscle. Okay, this you have to remember. Okay, otherwise the eyes doesn't see what the mind doesn't know, right? So you have to know first in order to detect the abnormality. So SO4 LR6, remember that short form. SO superior oblique, 4 cranial nerve 4, which is your trochlear nerve. LR6 lateral rectus, lateral, as the name suggests, lateral rectus. So it is located here. Medial is, this is medial kan? Closer to your nasal is medial, lateral rectus. Superior oblique, as the name suggests, superior and oblique. Okay? Okay, so SO4, LR6. The rest, semua cranial nerve 3. Okay? In that sense, quite simple. Okay, and then not only you have this extraocular muscles problem, you also have intrinsic eye muscle itself punya problems. The intrinsic eye muscles controlling the pupils itself. Okay, you can have dilator pupillae problems. Okay, it's supposed to dilate the pupil. Okay, and then you have sphincter pupillae. It's supposed to constrict the pupil. Ni sympathetic, ni parasympathetic. And then you have the ciliary muscles. This. Okay? That controls your accommodation for near visions. Okay. These are the roughly, briefly, the abnormality that you need to look for. Okay? For example, if the problem is on the right side, we take one side abnormality sebagai contoh, alright? Third nerve palsy, okay? Primary position first. Determine the primary position first because we inspect first, right? So you see the patient look straight at you, okay? So that's primary position, okay? Third nerve palsy, eye will be down and out. You see, down and out. Because why? We mention this later, okay? After 4 and 6. Okay, and then fourth nerve palsy pula. Primary position, the right eye turns upward, up, out. Okay? Cranial nerve 4 tadi, which muscle?
SO4, superior oblique.
Superior oblique. Sini. Bila dia lemah, dia lemah. So, I pergi kat sana. Understand? Okay? They cannot hold it. Okay? Okay, to primary position. Okay, but if the patient turn right, you cannot see any obvious squint lah. Because memang eye dia up and out, kan? Okay, but if you ask the patient to turn left, okay, when do we detect this? When we do the eye movement, kan? So you can detect turn right, turn left, up, down. Alright? Okay. Semua orang dapat ke so far?
Dapat.
Okay, bagus. Okay, but if you ask the patient to turn left gaze, the right eye will elevate more, okay, and then the double vision will be more obvious. Okay, cranial nerve 6, which muscle tadi?
Lateral rectus.
Lateral rectus, LR6. Okay, so lateral rectus is here, kan? Lateral, correct? So bila ni not functioning, the eye will be turns medially. Dia tak dapat nak hold, jatuh ke sana. Okay. So if you ask the patient to turn right, they cannot adapt the right eye because ni tak boleh function. Okay. Lateral rectus simple adduction movement. So kalau dia rosak, cannot adapt eye to the right side. Okay. But when the patient turn to the left side, you cannot really differentiate. Okay. Okay. So this one primary position down and out because ni kan all the other muscles except for LR6 and SO4. Okay. Understand? Okay. Maybe you have to revisit later. Okay. Okay, roughly. Okay, just a cartoon ni. Simple understanding. So, third nerve ni down, out, kan? For example, in your vasculopathic tumor, if the patient has aneurysm, for example, okay. Fourth nerve, for example, if they have congenital trauma, okay. Sixth nerve, okay. For example, if they have high intracranial pressure, ni left side pula affected, okay, at the primary position, okay. Okay, move on to cranial 5. So cranial 5, as I mentioned earlier, ada both sensory and motor. Okay, so you ada V1, V2 and V3. All three kita assess the sensory examination and the motor examination. Okay. The technique tadi you have watched the video, kan? Okay. Facial nerves. Facial nerves ada transmits motor information to the muscle of your facial expression. Okay. The facial nerve also ada sensory component, anterior 2/3 of your tongue as well. Okay. So for sensory part of your facial nerve, ask the patient if there's any change in their taste lately. Okay. For the motor part, then we do just like how the video showed earlier. Okay, raise the eyebrow. Okay, close their eyes, blow your cheeks, smile while showing the teeth. Okay, and whistles. Okay. Okay. So for facial nerve, determine either it's upper motor neuron lesion or lower motor neuron lesion. How do you differentiate? Upper motor neuron will spare the forehead. Okay, this is the determinant. Okay, because the pathology, upper motor neuron lesion and lower motor neuron lesion are different. Understand? Okay, so when we assess the facial nerves for any palsy, facial nerve examination, look at the patient. Okay, raise the eyebrow. Okay, for example, if you have asymmetry, okay, then right facial, they have drooping of the right side of the face, for example, right side. Okay, then you suspect there is facial nerve palsy going on, right? Okay, and then ask them to raise their eyebrow. Whether they can raise the eyebrow. Macam mana, how do you determine whether they can raise the eyebrow or not? See the wrinkles. Okay, if let's say there is pairing of the forehead, okay, then it is upper motor neuron lesion. Okay, if the forehead also is affected, okay, then it is lower motor neuron lesion. Okay, lower motor neuron lesion is like your Bell palsy, poliomyelitis, otitis media, or herpes zoster. Kalau upper motor neuron, more of in the intracranial lah. Okay, stroke or tumor. Okay, this is what? Upper motor. It's difficult to see here because the patient doesn't raise the eyebrow. Okay, but we can see roughly here the forehead is affected. Okay. Next is your cranial nerve 8. Okay, sensory information about your sounds and balance from your inner ear to the brain. So vestibulocochlear nerve has no motor component. Okay, so you ask first before you even start whispering to them. Okay, ask the patient if they have noticed any changes in their hearing lately. Okay, and then you can whisper lah, or just use like this. Okay, whether they can hear it or not. Okay, and then do your Cns and Weber's test. Okay, so please know how to interpret your Cns and Weber's test. Okay. Okay, for Cns test, okay, normal result if air conduction is better than your bone conduction. For example, if this is your tuning fork, okay, you vibrate them, put on the master process. Okay, tell me when the vibration stops. Okay, finish. Then you put here, the opposite end. Can you hear it? Can. Meaning? Yes, Cns is positive because it's not it's normal lah. Your air conduction better than the bone. Okay, understand? Okay, so if the Cns is positive, it could be normal, or patient could have sensory neural deafness. Okay, air conduction better than bone. Cns positive, Cns positive. Okay, kalau dia negative, you know, okay, patient have conductive hearing loss. Okay, okay, so if the results is positive, kan, how to determine whether really that is normal or patient has sensory neural deafness? From Weber. Okay, how do we know from Weber? You vibrate the tuning fork, put on the forehead midline. Okay, ask which side they hear louder. Okay, so normal people will hear the sound equally in both ears, but if they have sensory neural deafness, they hear louder on the affected side. On the side of the intact ear. Okay, so if they say it's louder on the right side, meaning the right side is the normal one, the opposite side is the abnormal one. Okay, understand?
Yes.
Okay. Okay, as opposed to your conductive, if they say it's louder on the right side, meaning the right side is the bad ear. Okay. Okay, move on to accessory nerve. Okay, simple, transmits motor to the SCM and trapezius. No sensory. Okay, simple. Ask the patient to resist your shoulder. Ask them to resist you pushing the shoulder down. Okay, and then this one lah, SCM. Okay, ask them to turn right side and then you push to the opposite direction, left side, and then you push towards the opposite direction. Hypoglossal nerves, okay, motor information to the extrinsic muscles of the tongue, okay, no sensory component either. So, open their mouth, ask them to open their mouth, look inside the tongue, is there any fasciculation, okay, and then at rest, look whether the tongue is deviates or not. Okay. When the tongue is protruded. Okay. When the tongue is protruded, you see, is there any? Is it just in the midline or is it deviated towards right or left? Okay. For hypoglossal nerve, the tongue will deviate towards the lesion side. Okay, let's say when you ask the patient to open your mouth, stick your tongue out, and then the tongue deviates to the left side, meaning that likely there is a possibility of left hypoglossal nerve palsy, okay, towards the lesion. Okay. Protruded tongue deviates towards the left, meaning left hypoglossal. Okay. Okay. So just some each of the nerves list, okay, and the possible problem that could occur, okay, and the signs that you would find. Okay, a summary. Okay. So this is just a summary of what I have explained earlier. Okay. Okay nah. Okay. Kenapa rasa macam I didn't mention about glossopharyngeal lah, this one. Okay, I think terskip tadi. So glossopharyngeal, okay, motor to your stylopharyngeus muscle, elevate the pharynx. Okay, how do you examine? Okay, also from the sensory to the taste. Vagus nerve, motor towards the muscle of the mouth. How to examine the gag reflex? Okay, and you ask the patient to say ah. Okay, open your mouth and say ah. Look at the palatal movements. Okay, bila kita sebut ah, our palate will go up. Okay, you see if the movement is present or not. And another one, if there's any asymmetrical elevation of the palate and uvula deviation. Okay, as opposed to your hypoglossal, in your glossopharyngeal, the uvula, okay, deviates away from the lesion. Okay. Alright, but in real exam, okay, I mean in your exam, you just have to offer the gag reflex. Okay, you don't have to actually do it. Okay, how do you do gag reflex? Anyone know? Macam mana?
Dalam.
You ambil tongue depressor and
Tak ke dalam.
just put down over the pharynx. Okay, patient gag. You assess whether it's strong, it's absent, present or absent, or is it strong, is it weak? Okay. Any questions so far? Okay. So after you finish your examination, just mention to complete the examination. Explain patient that you have finished the examination, thank them, and summarize your findings. Okay, so example of what you can say: today I've examined this Mrs. Smith, this is for your own female, general inspection, okay, comfortable at rest, normal speech, okay, no medical equipments around the bed, okay, If it's normal, examination of all 12 cranial nerves was unremarkable. Okay, if there's any abnormality, then state lah the abnormality that you find.